Okay, now if we're dealing with a hypomobility, we can now think about mobilizing it. We know that with the exception of the trapezioscaphoid joint, essentially the proximal face of the bone is convex, of the distal bone is convex. So if we're gliding that bone, we need to glide it in the opposite direction. We also, when we're dealing with end range techniques, have to allow for the conjunct rotation. So I'll give you a couple of examples of how we can mobilize some of these intercarpal joints. And if we look at the radioscaphoid joint, for example, in order to mobilize this, I'll put the joint into an extended position up to its barrier using hold relax techniques to get me there. And the the conjunct rotation will be a lateral rotation of the scaphoid. It fans as it extends, so we'll produce that. And then the glide will be a ventral glide. So I'll either push the scaphoid down, or often it's more comfortable to simply stabilize the scaphoid and pull the radius up as we maintain that conjunct rotation. To deal with the medial side of the hand, or the ulnar side of the hand, then stand on its radial side. It's a lot easier for the therapist to do it this way. And we'll stabilize, let's say we're looking at flexion, for example, of the triquetral-hamate joint. So we'll flex that joint to its barrier, there, medially rotate the hamate, and then produce a dorsal glide for flexion, like so. For the sagittal joints, we'll come face onto the hand now. Again, this is easier than stand on either side. And these ones, if we have a loss of these sagittal glides, then we don't have to worry too much about the flexion extension component. We can come into this position, simply stabilize one of the bones and produce the glide at the other bone, like so. Okay, now these principles should be carried on through the wrist. For example, if we was mobilizing the triquetromeniscal joint for extension, then we would extend it at its barrier, make sure that we ulnar deviate to bring it into contact, and then produce medial rotation when we did the palmar glide for extension. Okay? So it's just a matter of understanding the biomechanics and the shape of these joint surfaces. Okay, if we move into the hand now a little bit further and we look at the first carpometacarpal joint, this is an unmodified sellar joint, and it's got 2 degrees of freedom. It can ab and adduct, like so, and it can flex and extend, such. Now, for ab and adduction, the metacarpal presents a convex surface. So as we abduct, the glide is dorsal. As we adduct, the glide is ventral. For flexion and extension, it presents a concave or a female surface. So as we flex, it will glide into flexion. As we extend, it will glide into extension, into the same direction. So if we look at mobilizing for the end range of abduction, for example, I will stabilize the trapezium, grasp the base of the metacarpal and take it to its abduction barrier, again using hold relax techniques, induce and emphasize the conjunct rotation, which is medial now, there, and then glide the radial head back towards the palm of the hand, that is dorsally. If I was doing regaining adduction, I would do the opposite. Adduct it, laterally rotate, and glide it palmally. For flexion, take it to its extreme of flexion and induce the conjunct medial rotation, and then I will glide it in the same direction. So stabilizing the trapezium, I will glide it across the palm of the hand, and for extension, I will take it to its extended position here, laterally rotate it for the conjunct movement, and then glide it basically almost along the radius in that direction as I stabilize the trapezium again. For the spin of medial and lateral rotation, if I wanted to go after that separately, then I can do that with distraction. And there's a good deal of traction at this joint, and it's the flexibility and the laxity in the capsule that allows the spin to occur. So I would position the joint into medial rotation, for example, and then apply the traction. Or if I was after lateral rotation, I would laterally rotate it and then apply the distraction there. This is also a decent technique for pain, if I want to reduce pain. But in this case, I obviously wouldn't go to the extremes of medial and lateral rotation. I would leave the joint in its resting position, which is about where it sits normally, and then apply very, very gentle traction to the joint for pain relief, a grade 1 or a 2 technique. If we come down onto the metacarpophalangeal joints now, these have 2 degrees of freedom, being modified ovoid joints. They can flex and extend, and they can abduct and adduct. And the metacarpal presents a concave surface for these movements. So the glide will be in the same direction. So for testing, I'll leave it in its rest position, again about where it naturally falls, stabilize the metacarpal, and then stabilize the metacarpal and grasp the phalanx, and then I can simply do a dorsal glide for extension and a palmar glide for flexion, a radial glide for abduction, and a ulnar glide for adduction. And I can also test the conjunct rotation that's available at this joint by simply twisting the bone here. Now, to treat this, the conjunct rotation of this joint is lateral as it goes into flexion. So I'll take it to its flexion barrier, again using hold relax techniques, laterally rotate it, and then glide it palmarly in the direction of flexion. If I was going after extension, I would do the opposite. Bring it into the extended position and medially rotate it and glide it dorsally. Okay, now the last joints we have to concern ourselves with in the hand, and of course these principles are applied all the way across. At the interphalangeal joints, these have 1 degree of freedom as they are modified cellar joints. They can flex and extend. And the distal phalanx presents a concave surface for this movement. So to stress test these, we'll put it into the extreme position and ab and adduct it. And particularly the distal joints have plenty of ab and adduction available even in their close packed position. And they're designed this way so that they can be stressed into different positions when you're picking up irregular objects, so it allows the hand to conform to the irregular object. For mobilizing these joints, you would think that it would be a glide, and in fact the gliding at these joints doesn't work very well at all. And to mobilize these joints, it's much better simply to do the osteokinematic. That is, if the joint can't flex, we simply stabilize the proximal phalanx and push the distal phalanx into flexion, again using hold relax techniques and oscillations. But rather than trying to do the glide, of which there is a minimal amount, just come in and stretch these. These joints are very difficult to treat anyway, and this is about the only really effective way of doing it. And to enhance that, we can do frictions. And they work really quite well here because the frictions are, the ligaments and the capsule are available to them, they're superficial. And for the lateral side of the joint, you simply grasp the finger on either side, like so, bring your other hand on top, and the finger inside. So I'm actually doing this with the finger and rubbing the finger underneath my left index finger and thumb. So I'm doing the collateral ligaments. To do the superior and inferior aspects of the joint, I'll grasp here and not move the fingers here, and simply move the finger from side to side so that it is rubbed under my right thumb and index finger. And after doing this for a few minutes, then these stretches become a lot more effective at increasing range. But even so, when you see these joints and they're swollen and lumpy, they're not the easiest joints in the world to treat.